Hi everyone! Welcome in this January webinar, the second of the year. Welcome in the CANCEPT Meet&Share. Thank you very much for coming in this late afternoon. I will share my slide up.
Is it now 5 p.m. there?
Yes. Yeah, it's 5 p.m. in France right now. What time is it in yours? Ross, what time is it by yours?
Oh, we're at 10 a.m., 10 a.m. in the morning.
10 a.m.
So we're getting a bad time for people with little ones who are trying to get their little ones ready for dinner and getting them home and settled in, right? So that might weed out some people in that group. Oh, there we go.
Yes, that's our network. So I think we will slowly begin. So welcome everyone. Thank you for coming to this Meet&Share. We are really happy to have you today. So it will be in English. Sorry for the French, but you will be able to talk in French in the conversation and in the Q&A, and we'll be translating in English. So don't worry at all. So just to launch this webinar, so it's a monthly webinar, the Meet&Share, and the idea is to bring together different stakeholders, citizens, patients, researchers, professionals, to talk about primary prevention. And these webinars are held by the CANCEPT network, which is a network about research in primary prevention. And this network is a national network made of 7 different partners, academic partners, but also field partners from across France. So social marketing, we have nutrition epidemiology, cancer research, social inequalities, patient and participatory research also, PPI, behavioral science. So you can see it's really broad. And now I'm really happy to give the floor to Ross Brownson. I will stop sharing my screen so you can also share yours, Ross. And we will be having a half an hour presentation from you, and then we will have time for talk. So we'll be able to have questions and reply to these questions. So Ross Brownson is a professor at Washington University School of Public Health, and he will be having a talk on the concept of evidence in implementation science. So the floor is yours, Ross. Thank you very much for being here.
Great. Thank you, Pauline. And glad to be with you. I wish I was with you in person, but Zoom or Teams is just as easy. So let me go ahead and put my slides up. And I'm in St. Louis, Missouri, in the middle of the U.S., part of the U.S. where most people who visit don't come because it's kind of hard to get to, but I'm glad to be here and join your group. I'm going to talk about evidence today, a bunch of different pieces around the concept of evidence. And of course, in this field of implementation science, evidence is sort of the cornerstone. We don't do anything without evidence. And so that's the start. And I know some of you are very familiar with implementation science, and I didn't put any slides in on this, but I thought I would give just a very quick overview of the difference between effectiveness research and implementation science to orient us. So in the way my colleague Jeff Curran has explained it in the simple language of implementation science, the intervention or the practice or the new innovation is the thing. So think about that as the thing. And effectiveness research, or sometimes we call that intervention research, looks at whether the thing works. Does it work or not? Implementation research then turns around and looks about, if we've got something that works, we've got a thing that works, how do we increase the use of that? How do we increase the uptake? How do we make it easier and better for people to be able to use and apply the thing? And the implementation strategies are the stuff we do to use the thing. We will look at how well we're doing with that, how much. And then, of course, in some cases, it's not implementation, it's de-implementation, where we're doing something that is not effective or is of low value in a clinical setting, and we try to lessen the use of that. So hopefully that gives a little bit of an orientation. In the next 30 minutes or so, I may be just a little bit beyond that, but around 30 minutes, I want to cover these categories, a little bit about some definitions and types of evidence, and how we generate evidence, this core concept around context, implementation science has a big value on context and external validity and health equity, or the reduction or elimination of health disparities, another way to frame that. Uses of evidence for what, on what, and for whom, and I'll explain that in a minute. And then just a little bit about some tools and resources that really will be coming out of an article we published a few years ago. And I think this cartoon sort of sums up why a lot of us are in the field. In other words, the latest research shows that we really should do something with all this research, not doing research for the sake of research, but doing it to improve health, allow people to have the opportunity for a better and healthier life, increase equity, and spread evidence-based practices. Okay, so for a little bit of a backdrop here, I'll go to the continent in a minute, to the European continent, but to start off, and I know you work in cancer, this is a diagram that makes your head hurt a little bit, but this is what a 7-layer multi-level model for cancer care, developed by Steve Taplin at our National Cancer Institute, published over 10 years ago now. I won't spend much time on this. All it's saying is that we live in a complex multi-level world. If you're trying to change individual behavior for cancer prevention, or you're trying to get people screened, or you're trying to treat cancer after it's already diagnosed, that happens for an individual, but they're influenced by all these other levels. And they did a really nice job in this paper explaining some of the important things that happen at different levels. For the implementation science part of this, it's often at that organizational level on up, on different levels, depending on the kind of issue we're working on and the other pieces of it. You all are probably very familiar with John Snow and the mapping of cholera in London and how important that was. In many ways, and the pump handle here, you see dramatically, when the pump handle was removed, we went from 700 deaths from cholera down to 0. I guess the pump handle in a way is the policy or environmental change. We don't have many pump handles left. In other words, we don't have a lot of risk factors or cancer-related interventions where there's an improvement of 10-fold or 20-fold. If you think something like smoking and lung cancer, there aren't a lot of those left. So often we're dealing with weaker associations that have a lot more challenges. So that's another piece that's important to keep in mind. And then another piece is that evidence synthesis, the gathering of the evidence to knowing what works, has been around a very long time. In the US, it's been around since the 1860s, when we started our National Academy of Sciences. We had meta-analysis introduced around education. We've got the work from Archie Cochrane in the UK that began to establish the idea of evidence-based medicine. Evidence-based public health developed sort of in parallel in Europe, Australia, and in the US in the late 1990s, the formal parts of that. And then we have these wonderful collaborations like Cochrane, Campbell, in the US, the Clinical Guide, the Community Guide, that work on evidence synthesis. This is often a place to go for finding what works. And a word here about what in our field of implementation science is really the seminal publication, a book published by Everett Rogers back in 1962 that looked on how innovations grounded a lot in agriculture, how agricultural practices spread or don't spread. And I won't spend much time on this, but it's the characteristics of the innovation, it's the decision-making process, it's how things are communicated, it's the characteristics of the system within which the innovation is being disseminated or diffused. And then it's change agents. And those are people like you, they're the implementers, they sometimes are advocates or policymakers. And so this lays the foundation for now, what is this, like 60 years ago, for the foundations of implementation science. And that's just an important thing to know. All right, a few core concepts. And this is my little attempt to bring a little French culture into the conversation today. You all are probably very familiar with Voltaire, the French philosopher, writer, who has many, many great quotes. And one of my favorite quotes in my academic and perfect life is, "Don't let the best be the enemy of the good." and the cartoon to go along with that. And I think that's important in evidence synthesis, that we don't wait around for perfect evidence that someone with a very academic look at the world might want, but we're looking for things that have enough evidence of effectiveness that they should apply. Because as the cartoon said, if we wait till everything is final and definitive, we're not going to be doing much in terms of prevention and control of cancer. When evidence comes to this field of implementation science, it comes in many different forms. It can be causation, etiologic research. It can be intervention effectiveness, that thing, or it can be implementation within the context. And our argument in the paper that I reference at the end that's open access is that we often have focused way too much on a narrow definition of what works. For example, only developed through randomized trials, when things like policy change might affect even a larger group of the population, and yet it's nearly impossible to study many policies with a randomized design. Context is important. I already talked about the multi-level part. That's the characteristics of this clinical setting, the community setting where you work. And then I'll spend a little bit of time today on external validity as well. We have a lot of gaps in evidence around equity and equity-focused evidence, in part because often people experience equity are a smaller slice or proportion of the population, and so we often don't have the numbers that we want, and they're often left out of a lot of the trials, especially the trials we've done here in the US. We need a robust definition of evidence. That's one of the premises of our work. And I'm going to give you a listing of different types of evidence. You've got the things that you would typically think about from a research perspective toward the top. We've got things that are important for public health, surveillance data, program evaluation. We have qualitative data. And then down toward the bottom, we have things more like word of mouth and personal experience. All these things come into play. They're all different types of evidence, but you probably don't want to base the next 10 years cancer plan for France based on word of mouth and personal experience. So we try to gravitate toward the top. As evidence improves, it often moves up the continuum here. And then another quote for you, just like beauty and art, evidence is in the eye of the beholder. What one of you would think about as evidence is probably very different than what a French policymaker would think about as evidence. And so that's important to keep in mind. You would be looking at more rigorous, systematically collected data. You would think like peer review as part of the process. A policymaker might think of, well, I have a good story from one of my constituents, and that's good enough evidence for me. So that's important to keep in mind as well. We argue, and we weren't the ones who originally thought of this, we're just thinking about it as a way to build on the literature that's already there. The idea that we need an evidence typology perhaps more than a hierarchy. So build the type of evidence that's best fitting for the kinds of research questions we're trying to answer, but that might be a typology rather than a hierarchy. Mark Pettigrew wrote a nice article some years ago where they used the British term horses for courses. Some horses run very well on a wet track, some horses don't, and some run better on a dry track. And so we ought to fit our health-related information evidence in a way that we would think about in a horse race, if that makes sense. There's another article more on intervention evidence by Hassan et al., where they talk about some of the core elements of an intervention, when it can be adapted, when it can't be adapted. How do we support high quality implementation? That's where we think about those implementation strategies, the things we do to implement an evidence-based practice, how we generalize, that gets to external validity, and then what the outcomes are and how we decide on those outcomes. When you think about this concept of evidence for what, we like to break evidence into these three categories, and they overlap, so they're not completely clean categories. Type 1 evidence would be something like smoking causes lung cancer. That's etiologic research. It measures burden. What does that tell us? Well, that tells us something should be done about smoking. It gives us very little specificity on what should be done. That's where type 2 evidence comes in. That's the relative effectiveness of different kinds of interventions, the thing, if you will, in the wording I used earlier. That tells us that price increase with a mass media campaign would reduce smoking. So that begins us to look at intervention evidence effectiveness. We have much more of that kind of evidence than we do of type 3 evidence, but much less than we have of type 1 evidence. Type 3 evidence is implementation evidence. That's the adaptation, the implementation. If we've got an effective tobacco control project or program, how do we get that done in areas that have a high smoking rate? We have much less of that kind of evidence. Type 3 evidence tends to be a little bit more qualitative than type 1 and type 2. And the important thing is we need to have all three of these kinds of evidence to really do implementation effectively and efficiently. Of course, other kinds come in here like economics and economic evaluation, but this is the category we use when we're training people in evidence-based practice. We also want to think about evidence on what and the kind of evidence we want to collect. And here, you always start with some kind of a theoretical framework or model. You want to think about what questions we're asking, what kind of evidence relates to those questions, and then begin to think about design, evaluations, and then, of course, what we're going to measure. So that's important to keep in mind. Another way to think of the what of evidence, if you will, is to think about qualitative, quantitative, or mixed methods evidence. And I have no training in qualitative research, but I've come to really appreciate how important it is, and especially when you can do mixed methods evaluation or mixed methods of generation of evidence, how much more powerful that can be, because it tells you more about the how and the why, when quantitative evidence tells you about the what or the how much. And so those blend together and are very important. And I know a number of you work in these areas as well. And so those who work probably more in clinical trials will be very familiar with randomized trials. A quote from my colleague Larry Green: if we want more evidence-based practice, we need more practice-based evidence, up in the upper right-hand side of the slide. We want to think more broadly sometimes about how we are designing something for ultimate dissemination. Is it only in the ideal world? Is it not in the real world when it's more effective as research? Too often trials aren't pragmatic. They're not realistic for the challenges a clinical setting is facing. And then policy evaluation is very important. And we'll talk a little bit about that later. A randomized trial sometimes can make it difficult to translate to the real world that's not randomized. And then we move from an efficacy trial, something in a very controlled setting, to a more real world trial. We often get what we sometimes call a voltage drop. In other words, the effectiveness drops off sometimes precipitously as we move along. A little bit of a word about external validity, and this is from the children's tale, Three Little Piggies. And we're going to have three paradoxes. The internal validity, external validity, the more rigorously controlled the trial is, the less real world that it can become in terms of scalability and generalizability. The specificity generalizability paradox is that the more we make something locally relevant, assuming the local is different than other regions of France, for example, the less generalizable it is to other parts of France or other local communities across France. And then the homophily distancing paradox is this idea really of sort of community engaged research. The more we interact with, homophily comes from, I think, from sociology, and it's the tendency of individuals to associate or bond with others like them. The saying, birds of a feather often flock together. So the more that a community is cohesive, that it's going to be relevant for them locally or within a certain process of community engagement, the less likely it is to be able to be generalized and to be externally valid. So those are important things to keep in mind around the concept of external validity. I'm a baseball fan. I won't spend any time with baseball because I don't think it's the main sport in France, but I will say there's a famous quote from my favorite baseball movie called The Field of Dreams that says, if you build it, they will come. So the idea there is you build the baseball field, people will come and use the baseball field. And that's not always true. What diffusion theory has shown is when you have a new innovation, you get something like 5 to 10% of the target population who adopt it very easily. You've got another probably 5 to 10% in the other tail. that says almost no matter what, we're not going to do it. And then you have a very large group in the middle, sometimes 60 to 80% of a group, who need something else to get them to use the evidence. So if you build it, will they come only works for a small percentage. The other part that we've studied quite a bit is this idea of dissemination research, and we call that D4D, or designing for dissemination. And the idea here is that the way that academic people typically disseminate research here, and I'll list just a couple of these, in what they do is obviously the old publish or perish, how we disseminate our research. What has the most impact on our career? Very clearly, publishing does from the clinical world. Impact on practice and policy is much smaller, only 16% from academic journals. These data come from the US and Canada, data we collected 5 or 6 years ago. And then the other one I'm going to highlight is face-to-face meetings has perception of 0 impact on career. This is reported by researchers, but estimated 40% impact on practice and policy. So this mismatch is important to keep in mind in how we design our studies in the first place. And then a little bit about equity. I pulled in a little bit of French data here. This is data on life expectancy in France from 1900 to 2023. Remarkable life expectancy gain here from 45 years to 83 years. And this is one of the higher life gains from different regions of the world over this roughly 125 years. Put another way, over this time period, for every 1 hour of time that elapsed, on average, we gained 32 minutes of life. Think about that. For every hour, we gained 32 minutes of life on average. But of course, the equity part of this is we know that people, for example, in lower income groups, didn't gain as much. They might have only gained up maybe 5 years less life expectancy gain. So equity would get at the idea that we need to do better with social justice and reaching a bigger population. And this is a paper we published, I guess in 2021 now, about just making the argument that we need to move toward equity in all the different areas we work in and give some recommendations. And pointing the difference between equality, giving everyone the same thing, versus equity, giving people, in this case, a bicycle or a moving device, what's going to get them to the point where they have the ability to be healthy. And we need to be more intentional about applying this. This is particular to implementation science, but it applies across all areas of cancer prevention and control. We define on this three broad categories: limitations of the evidence base, our measures and methods, and then context, with some examples that go through those. And what we did in this paper is we provided examples within these, and then we set up a set of 10 recommendations that I won't go through in detail. This is the first one around the evidence base itself, some issues around social determinants, building equity in all policies, and then we go on to build this out in a number of different areas that we think are important for equity. And equity is important in all parts of the world. How it plays out in France and different regions of France is going to be different. It's going to be different internally across France, and it's certainly going to be different with European neighboring countries or with other countries across the pond or in Australia or any other sort of westernized culture that you might want to look to or learn from, or them learn from you. A few of the bottom lines that we've tried to set out around equity and implementation science is remembering that we should start with a justice lens, that we're trying to equalize things and level the playing field. We argue that every project ought to have an equity focus in some ways. It might be the central goal and the feature of the project, all the way from the original idea to the research questions, the conceptual framework, the activity. In other words, it's through the fabric of the entire project. Or it might not be a singular focus, but at least we ought to measure and make sure that no one gets left behind, that an existing program or policy doesn't disadvantage a certain population over another population. And then I want to spend just a little bit of time on the concept of evidence for whom and a little bit about policy-related evidence, okay? Think about the audience. I want you each to think about one of the main audiences for your own research. And that might be a policymaker, it might be a practitioner, it might be a broad view of the general public. And then think about how you communicate that in a gain framing, that is the life saved versus a loss framing, the number of lives lost, and what's going to resonate with that audience. Audiences across communication research want messages that are perceived as unbiased and credible. They want to be delivered in the way that is accessible, packaged appropriately, and understandable, and especially for policy-related issues, how it crosses political divides, partisan divides. This is a model. This is in a paper. It's open access. I'm going to send the slides after, so these will be posted. And it just gets us to think about not just what we're doing and what we're putting out, but the source of the message, where it's coming from, the message itself, who's receiving it, and the channel is how we're disseminating the message. And I'll give you an example in what we call our planning matrix that I've outlined here for 3 core audiences. So you want to think about the characteristics of that. Let's look at the policy one at the bottom set of roles. Well, they're going to have some are highly committed to health, some aren't. They have a very wide set of professional backgrounds. They typically have short time horizons for their outcomes, often in the time frame when they're being reelected. They want to serve their constituents. They want to have a return on investment. They want to get reelected. And then the channels might be stories. They might be summaries of evidence. And maybe even more important than what the evidence is, they want to be delivered by someone they trust and believe, and often people they know. So that's important to keep in mind. It's also important to keep in mind the idea of burden of proof, or the evidence threshold. The evidence threshold for you as a researcher or a clinical practitioner is very different than that for a public health practitioner, and very different from a policymaker. And so that's important to keep in mind. And what threshold do we want to attain through a regulatory agency versus a practitioner serving a group across the country, France, or another area, another neighboring country, another setting that's important. And then the policymakers, I spent a bit of time on those. Couple of notes about policy-related evidence. The little diagram at the top, I don't know where this thing came from. One of my favorite sayings about policy is the 2 things you never want to see being made are legislation and sausage, because they're kind of messy and you don't always know what the ingredients are. There's a thing we call the inverse evidence law, that policy interventions probably have the biggest impact on our health and ability to change systems, and yet they're the hardest to prove if we use the sort of randomized trial approach to identifying quality evidence. We have a lot less control over the intervention, the policy, than we do for other types of intervention research, and the time frames are different, and I already mentioned that one. And I'll show you a little cartoon. Here you are outside on a nice sunny day. Someone in the room, where am I? You're 30 meters above the ground in a balloon. You must be a researcher. I am. How did you know? Because what you told me is absolutely correct, but completely useless. You must be a policymaker. I am a policymaker. How did you know? Because you don't know where you are, you don't know where you're going, and now you're blaming me. So funny little cartoon, but also true. And so what we need to do is think about how we better connect the people in the balloon with the person down below fishing. And we need to do a better job with that if we're really going to impact health and cancer prevention and cancer care. And then my last, I think, substantive slide, and I'll spend just a minute on some resources, is a shout out to the Beatles and the song that goes "And in the End." Ending here, remember to keep our eye on the prize, and the prize is impact. It's making a difference in people's lives. It's improving health. It's improving cancer prevention, early detection, treatment, survivorship. The so what of implementation science depends on evidence. It depends on the evidence for different audience, how we reach them. How do the academic outputs relate to what's relevant in society? Most of the partners I work in public health could care less about how many publications I have. They care about whether what I'm proposing to do and work with them on is going to improve their delivery of public health services and ultimately improve health in their local community. Impact frameworks can be helpful in reframing and ending our work in a positive way. You're probably familiar with the Research Excellence Framework that's been used widely in the UK and other places in the world, especially in Europe. And the translational benefits model, translational science benefits model, have been developed here at WashU and has been used widely in the US. Impactful implementation science needs to focus on multiple things, but especially speed, scale up and sustainment. How do we move to a larger scale and keep it going? The implementation of things that aren't effective, and equity that I mentioned earlier. And reframing this and sort of shifting the academic ship isn't simple. Academic ship is kind of a big vessel, and it's sometimes hard to steer in a different direction, but it's worth the effort to try to do that and move it along. And so the article that I mentioned, and you'll have open access to that, is this one on revisiting concepts of evidence. And we put in there a table. This is the article published a few years ago. It was a fun article to write because it was kind of a brain dump of a lot of the things that we had worked on and had seen success with, but also some things that frustrated us that we tried to put together in a piece. So take a look at that if you haven't, if it's of interest. We described resources around these 4 broad buckets: engagement and partnerships, the research process, study planning, and then dissemination, scale up, and sustainment. And we basically, in the table of this, we listed out a series of tools. These are not going to be everything. You probably have a much better set of tools in your own setting around cancer care, cancer prevention, and things that are more relevant for France. And maybe these are obviously going to be more US focused, but the categories probably make sense. And some of these might actually apply for you, and some are developed more globally and some are more local. So a couple of messages, and then we'll save plenty of time for comments. Evidence, I could have gone a lot more depth, but hopefully you get the point that it's complex, it's multi-level, and it's contextual, and it's always changing in some form or another. The evidence base is always growing or shrinking depending on the issue we're working on. Too often we haven't looked as deeply at the equity-related issues that are structural and affect the root causes that often boil down to things outside the health sector. They might be health, they might be housing, they might be transportation, they might be justice. All of us need to think more about a broader definition of evidence and what makes sense to do the highest quality study for the kinds of questions we're trying to answer. And there are a lot of tools and resources that can help you on your journey so you don't have to reinvent the wheel as you're working on the issues that you're addressing. I put a couple slides of readings, just sample readings. These are no way comprehensive, but at least they give you some ideas. And the articles that I referred to in my talk are here listed as well. Almost all of these are open access, but if you have trouble getting any of them, just email me and I can send you a copy. Your library is going to have them as well. These are kind of mainline journals that I've listed out. So these cover a range of topics and relevant to pretty much everything I talked about in the last 30 minutes or so. And then this last one is just to say thank you, merci, and whatever language you want to choose here. And so I'll come off of the sharing and be very interested if people have questions.
Thank you very much, Ross. That was really interesting and clear. And before beginning into the real strong questions, like, do you use the French citations even in the US, or was it just for us?
Oh, some I do in the US, but some not, some for you. Voltaire I use all the time because that's one of my favorite quotes, because I think we don't think about that enough, but others I try to bring a little bit of French.
Thank you very much. So now let's dig into the real questions. So we have a questions from Yael, from our network, and from Reshape. So you use the terms sustainment and sustainability. What is the difference between the two?
The two between which?
Sustainment and sustainability. Maybe if
Oh,
my
yeah.
English
Oh,
is wrong, you can look at the questions also in the chat so I
oh,
don't
good. Yeah.
misread them.
Oh, good. Yeah. Okay. So I see.
The first
Yeah.
one from
Okay. So
Yale.
yeah. No, that's good. So sometimes people use them interchangeably, but the way I think of the difference is sustainability is used kind of in the early phase about what you need to think about, what potentially would lead towards something being continued. Sustainment is kind of measuring whether it is being continued or not. In other words, it's sustainment is kind of further along in the continuum. But I will tell you, because some of my colleagues here and in other parts of the U.S. are some of the experts in this, they argue about this all the time. And I think for this work, I tend to not get hung up too much on the terminology, but I think about, okay, for our team, we're doing work in sustainability, sustainment. Here's how we're using the terms. And I think that's good enough. In our book, we have a book on dissemination implementation research. We have a whole chapter on jargon, and it's a pretty long chapter on some of the terminology. And we found, and it's in the third edition now, we found even across building 3 editions, the language still hasn't gotten that much clearer. The reason we wrote this, actually, the first person who wrote this was a doctoral student of mine, like, I don't know, 15 years ago, Borsika Rabin. But I would say that that's kind of how I differentiate them. But I would also let you develop definitions looking at the glossary that we've developed and then adjusting it to what you think is going to make sense for your context.
Thank you very much. We do have a second question from Nii, from the CEPOP, from our network, also from CANCEPT. So in terms of planning and implementation study to follow on from a successful trial and ensuring an equity lens, for example, what frameworks do you recommend? Re-aim, on the CIFR, or others? Do you have any further tips? So on equity.
Yeah, that's a great question. If you do a deeper dive into those frameworks, they have many overlapping constructs. And so I think probably the 4 biggest network frameworks that I think I see being used are Re-aim, and then Prism is sort of an outgrowth of Re-aim that's a little more comprehensive. CIFR is another, and then another one is called EPIS, EPIS. And any of those have been used for equity. What I would do, and we have a tool, if I can get off my slides, if I can close my slides out, I'll put a tool in the chat in a minute. We have a tool that if you just Google D&I models, there's a tool that comes up that's a dissemination implementation models toolkit, and it lets you, we have over 100 different models and frameworks in there, and it helps you decide on which one's going to work the best for you. I would say Re-aim or CIFR could work, either one. I would say so CIFR tends to be a little bit more clinically oriented. CIFR tends to be it's been around almost as long, Re-aim's been around the longest, CIFR is the next. And so they also have a lot, they all have their own websites. I would also look at which ones has been used with measuring something similar to what you're trying to measure, because then you don't have to recreate all the measurement tools. You can build off of what others. I would also say that both in the US and the Canada and in Europe, the implementation science community is a very friendly, well-connected community. So if you have questions about one of these, just write to the author that developed them, and they're probably going to be very helpful in helping you think this through. But great question.
Thank you very much. And also for the audience, we will be able to keep going with the discussions on LinkedIn. So I will post all the discussion we have on LinkedIn. So don't hesitate if you need to come back to the resources. So we have a question from Anne Fleur, also from our team. I have a vocabulary questions. What is the difference between process evaluation, implementation, and dissemination?
Oh, that's a good question. So process evaluation, I think of as an evaluation tool that is measuring. So if you think about what I was talking about in effectiveness research, I would think about process evaluation, for example, if you're implementing a physical activity program and you're trying to get people to use a new trail that you've built in your local community. Process evaluation would be counting the number of people using the trail in a very simple way, or just talking with them about are they satisfied with the trail or not. It wouldn't lead toward any long-term behavior change. It's just as the program's being developed, are people using it? Are they satisfied with it? Implementation would be a broader, implementation is usually setting specific. So let's think of a clinical intervention. It would be, we've got a known evidence-based practice, so we don't need to do the process evaluation to determine whether the evidence-based practice works or not, but we're measuring implementation often in the organizational level. So for example, is it acceptable for the organizational leaders to implement an evidence-based practice? How many people is it reaching? How much does the intervention need to be adapted? So it's a much more complicated sort of questions than process evaluation, which is generally fairly simple. And then dissemination is a term, and I would say probably if I was reinventing the wording, I would not use separate terms of implementation and dissemination, but when the US NIH sort of developed some of this terminology, they separated. Dissemination, think about a broader spreading of an evidence-based practice across multiple settings in a more in a broader way that isn't focused on one single setting at one single time. But they overlap quite a bit in terms of the vocabulary. I hope that's helpful.
Yes, I think it is. Let us know, Anne-Fleur, if it's good on your side. We have a question from Beatrice, who leads the network. How do you navigate in your approach the sometimes thin line between legitimate expansion of the evidence-based and fake news?
That's a good one. Well, and fake news, I'm going to take as sort of, I'm going to include in that the role of social media in spreading the evidence base or the lack of evidence base. I think that that's something we're all grappling with right now. Depending on, Beatrice, if you're still on, tell me, if you can, tell me what you're exactly meaning about fake news so I make sure I'm on track with that, because fake news could mean a lot of different things.
Yeah, it's a large, thanks. I'm still on, but I wanted to leave it to Pauline. I think, yeah, it's a little shortcut in my question, but to make it accessible, you have, well, what are the criteria to assess the robustness of the expanded evidence based on experiential evidence? And where can you come close to, oh, my opinion is, and sometimes also with convictions, which, well, there is a path, but convictions, and then it comes to non-evidence-based and how do you say, which evidence which you cannot, which not representative, and which would comes to a point where it's not helpful to rely on it. And do you have any criteria how you approach this evidence and how you manage this situation in a context? Because well, personally, we have not been confronted in our participatory approaches with the situation, but we have regular from the scientific committees also questions how in the participatory approaches and in collecting experiences, how do we manage when we come to the point where the evidence-based, the experiential evidence goes to, well, more to conviction than to useful piece of contributions of the different perspective, and how can you assess this? And this is related also to my next question. How do you collect this evidence in a structured way as sometimes you do not have the time to do qualitative studies and interviews with the actors in the field you want to involve. And are there any tools, or do you have any thoughts on this for collecting this type of evidence, experiential evidence, in a structured way?
Okay, yeah, oh, I see what you're saying. So that there's a lot there. Those are good questions and comments. So I think that there's probably not a single formula for this. It probably is very contextual, but thinking about what you were talking about with participatory process, it's thinking about first of all, who your audience is, who are the participatory people you're trying to engage in the intervention process or the implementation process. What we've had success doing, so we will use things that, so we've worked a lot in physical activity promotion in communities around this region. So we'll take a list of here's a set of evidence-based practices that are well established from Cochrane or from the Community Guide or from knowledge translation in Canada that we know will promote physical activity at the community level. We don't start with that. We talk with conversation with our partners about what do you think needs to be changed or added to your community to get people more physically active. Often it's around the concept of walking. We list those out. We usually write them on a flip chart of some kind, list them out, and then we open up our flip chart and we say, well, there's a lot of connection between, often access comes out as one of the most important things. People don't access to places to be physically active, whether that's a health club or a trail or some other facility. So we look at ways where what we call the scientific evidence, often from systematic reviews, connects up with the community priorities. We also do, I don't know if you're familiar with the idea of concept mapping, but concept mapping is a really powerful tool for matching up what people are saying about what ought to be done, and then you get them to rate them on importance and feasibility. Because you have something that's very important for researchers or a local community, but is almost impossible to do. And so sort of that's a way to match it up as well. The access issue, when we're working with what we call the intermediates in implementation, often public health clinical practitioners or system level leaders, we try to ensure that they have access to the same evidence we have access to, but maybe more in evidence summaries, not in the original research that will take a lot more digging to come into. And then as much as we can, we involve them in the generation of new evidence. And I know that's where you were sort of coming from with the participatory process. But I do think that, like all of implementation science, this is contextual. So you have to sort of adapt the process. And then the fake news part of it, because I think of fake news as often like the social media part of how people get information. That one is really hard. I think the only places where people are having success in fake news is beginning to look at who are the super spreaders of fake news? How do we compact that? What are the messages that would offset that? There's a lot of evidence now that incorrect news, even harmful news, spreads more rapidly than accurate news because it gets people's attention, it makes them angry, it creates a sense of grievance. The current administration we have in the US has thrived on that because they put fake things out there, but they put it out so many times that people start believing it because it's almost like becomes a cult. So I don't know if that helps, but there's a lot of layers to that, and it probably is largely sort of contextual for the issues you're working on.
Yeah, thank you. I agree. There are a lot of layers, and it's graduate from the very well, what's usually considered the evidence, and coming to more experiential evidence, and then shifting to something which is less structurable and to handle in this context. But I think it's an important point because it's now through the social media and becoming more and more present on certain topics, and this is well, sometimes it's tiny line between it. So thinking about how to structure the experiential evidence. I think it is important also in a world, as you said before, where also, of course, qualitative approaches are really key in implementation and in prevention in more general, but where we have to also in some aspect be able to demonstrate the evidence in terms of numbers and quantitative aspects.
Good.
So I think we don't have any more questions. Don't hesitate if you still have questions, you can write them in French or in English. Also raise your hand so I can give you the mic to speak. We have Neve that have put an article from her colleague from a department in Toulouse on the transferability of their intervention from a little while ago. So we can also have a look at that.
And that's good. That looks good.
Maybe while waiting for the next question, I was wondering whether PPI, so involving stakeholders, patients, citizens, the one directly interested by the research, would be a way to help with equity also in your implementation science?
Yeah, I agree. So in other words, early involvement of the key stakeholders early in the process. Yeah, that is often what people do. I will tell you the biggest challenge we face, and I'm sure this is probably true in France, is like we get funding. So we might have a local community we're working with, and they've prioritized the idea of gun violence as a high priority. But then we go to our national funders and they say, well, we have funding for cancer or we have funding for heart disease, but we don't have, so like here in the US, the federal agencies don't even want to fund gun violence anymore because they've got this notion that, we've got the freedom to carry weapons all the time. So I think what we try to do with our local partners is start with, we might come to them and say, we've got an opportunity to do a cancer screening grant. The federal funders already told us it's on a certain topic. Help us decide how to do that rather than, because true participatory research would just open up, like, what's the most important issue in your local community and how we begin to get that. But that's often now how our funding structures are set up. And I would assume you run into the same thing in the work you do in France, right?
Yeah, definitely. Yeah. And I think also one difficulty we might have in France, if I'm not mistaken, is we don't have a word for implementation. We say implementation, so it's the English word that is used. And so it might have two meanings. Sometimes it's confusing because we use it to say we want to transfer an intervention from one context to another. Yeah. Or it can also mean, so that's a narrow definition of what you explain of implementation. It's just intervention transferability. But implémenter also in French means put in action. So it's that's also why it might be difficult in France, is the wording.
Yeah, no, that's a great point. And I found, like, we've done some work now with China where they're starting to move into this implementation. They had some of the same issues where there weren't really the words and we tried to survey people, but the surveys weren't making sense because they were drawn. We did kind of the same survey in Brazil, China, Australia, and the US. And it was really hard getting it to work in all the different countries because some of the words don't even exist across different cultures.
Yeah, and I think that's why Anne-Fleur asked the questions, because we have transferability in French, transfer of knowledge, implementation. Yeah. So it's all a bit the same, but also a bit different. And what you put in your paper is much more structured. Would you have a few advice that you would give to researchers that want to begin in implementation science, or that doesn't, like for us, I'm a nutritionist in behavior change. So what would you advise to people that are not specialists in implementation science to begin with it?
Yeah, I think to start with, sort of learn a little bit more about the field. I can send you a few kind of beginning articles on it, and then start reading some of this. you know, if I was kind of reinventing all the terminology, I would probably just use the term of knowledge translation or knowledge transfer everywhere. But you know, the U.S. decided it had to develop its own terminology, even though the French already had the Canadians already had the term knowledge translation or knowledge exchange. Sometimes they used. So I think develop the language and the wording that you use, and develop what's going to make sense in your context. And it doesn't have to use the word implementation or implementation science. And then there are quite a few training programs. I know there's different training programs across the continent of Europe, and identify whether any of those make sense, or maybe some of those are developed already in France, or could be developed in France in a smaller way. I know Ireland does its own training. I think there's some training now. I'm going to a meeting in Amsterdam, I think in the fall, where they're developing some of this. So it's building up, and I think develop it in a way that it really makes sense for your context. And I would say you don't need to rely on the way the Americans did it, but do what's going to make sense for you and in the French context, because it's going to look a little different.
Yes, thank you very much. I think one thing the CANCEPT or a network already do in terms of implementation is through to PPI. So because we involve patients, citizens, caregivers, we are able to know what's important for them and how to translate it in the real world in articles, but also in other form, in other formats. So it's better translated in the real world. That's one part we are doing, but there are many others, as you said in your presentation.
Yeah, no, I think that's a great idea, and I think that's a great way to go. And you've got a very vibrant network here, so I think you could take this on easily. Oh, good. I see they know about Ireland.
Yeah, Neve. Yes, Alan, I'm making good progress on this. Thank you, Ross. I'm afraid I'm going to have to go in a minute. Have a lovely rest of your day.
Yes.
So maybe, yes, we can wrap it up. So I'm just going to close the meeting, but Ross, you can stay on so I can say a few words just afterwards. But thank you very much for your presence today. And just to give you a bit of willing to stay for the next Meet&Share next month, we do have, I will just give you the topic. So next month, the topic will be it will also be in English, and it will be the thesis of Oliver Langselius, which is the first PhD from our CANCEPT network, and it will be on global avoidable cancer burden, the role of risk factor prevention and improvement of cancer outcomes. So that will be another international meeting, and the one after will be in French by a Canadian researcher on involving the DIAD in physical activity interventions. So thank you very much for your presence and for your presentation, Ross. It was really interesting and really clear. And I hope to see you all next month in the Meet&Share. Thank you very much.
Thank you, Pauline. Great to meet you.
So it's closed. Now we are just